used by ophthalmologists or case series. Introduction. CCF is an abnormal vascular connection between the IC and ECA. CCF on anatomical classification is basically on traumatic and spontaneous. Traumatic is majority, and on anatomical it is based on direct, in which we can hear the auscultation by a stethoscope, and indirect, in which bruit is absent. So I'm presenting the first case in which a patient came with complaints of protrusion of left eyeball and restriction of movement in left eye since 5 months and history of trauma 5 months back. On auscultation, bruit was heard. MRI showed dilated tortuosity of left superior ophthalmic vein compressing left optic nerve with an associated orbital proptosis. So management was endovascular coiling, and post-op showed decreased signs and symptoms. Post-op visual acuity on day 1 was 624, which improved from CF. Proptosis and chemosis was reduced, as we can see in the picture. Second case, patient came with complaints of swelling in right eye, which was gradual and progressive in nature, associated with pain, aggravated on movement. Visual acuity dropped from 6.6 on presentation to CF 3 meter in 2 months. Auscultation, bruit was heard. MRI showed the same signs of protrusion, superior ophthalmic vein dilatation, and DSA. We can see the direct CCF. Management was done CCF embolization with covered stent. Post-op day 1 vision was not improved, but the symptoms not improved. On 1 month post-op, 612 was the vision and intersegment was normal. Third case, bulging of left eye, which was sudden in onset, progressive in nature, redness in left eye, sudden in onset since first day, drooping of left upper eyelid, which sudden in onset with mild swelling of upper and lower lid since 1 day. Auscultation revealed bruit. On MRI, protrusion of the eyeball was seen, and treatment was done endovascular embolization using covered stent. Post-op vision was 618, and the symptoms improved, but pupil was dilated. On case 4, swelling, redness, diminution of vision in right eye since 2 months, associated with history of trauma 6 months ago. Investigation revealed multiple dilated abnormal flow voids in right cavernous sinus and significantly dilated superior ophthalmic vein, which shows direct CCF. Management was endovascular coiling, and post-op visual acuity was 612. In case 5, a 37-year-old man came with complaints of redness, swelling of the right eye since 15 days. History of RTA 1 month ago. It was associated with pain in the right eye radiating to back of the head, swelling of upper and lower lid. On examination, chemosis, dilated sentinel vessels, and 5 mm fixed dilated pupil. MRI showed superior ophthalmic vein thrombosis extending to cavernous sinus and large cavernous sinus with multiple abnormal flow voids and indirect CCF. Management was thrombolysis and endovascular coiling. Post-op vision was 636 and reduction in signs and symptoms. In discussion, CCF is primarily based on 4 types by the Barrow et al. Anatomical classification. Type A is direct fistula, and other 3 types are indirect fistula. So the first 4 cases which we saw were of direct CCF, and the 4th case which we saw was of indirect CCF. In conclusion, direct CCF are unlikely to close spontaneously, and upfront treatment is indicated due to risk of neurological deficit and worsening of venous congestion. Signs for urgent treatment of direct CCF includes visual impairment, progressive paresis of extraocular muscle, intractable orbital pain, bruit, progressive exophthalmos. The goal of treatment is to cease flow into cavernous sinus and reconstruct the cavernous and ICA. Combined transvenous and transarterial approaches can be used to preserve the ICA and pack the CS. In direct, we use transarterial approach, and in indirect, we use venous approach. These are my references. Thank you.
There is some disconnect between the title and the presentation. What was the stethoscope used?
Sir, we could hear the bruit on auscultation, sir, when we kept the stethoscope, sir. So, first 4 cases, we can hear the bruit, which is a triad in a sign of direct CCF.
Were any of these pulsatile?
Yes, sir. All first 4 were pulsatile, sir.
All were pulsatile.
First 4 cases were pulsatile, not 5th case, sir.
In any of these cases, the sentinel vessel was the only criterion for diagnosis?
No, sir. Proptosis, chemosis, visual acuity.
It can happen that way. That's
yes,
right.
sir.
What was the etiology in these cases?
Sir, all were secondary to blunt trauma, sir. All 5 cases.
How long back?
Sir, they presented in the hospital when we first examined, but sir, they were from 6 months, 3 months, or 2 months, sir, like this, sir, till 15 days. That longest? Was the longest was 6 months, sir.
6 months.
That's it.